Healthcare Foundation. Thanks for joining today's monthly CIN webinar. Our topic today is Health Homes, Perspectives from the Leaders. For those of you who listen to a lot of our CIN webinars, we're taking a little bit of a different approach this month. We typically focus on very hands-on and tactical interventions that improve care delivery on the ground. And our webinar today has I think, a little broader perspective. Given so much interest in California that we're hearing, and nationally also, around the ACA 2703 Health Homes, we really wanted to bring together and offer up some initial learnings from these initiatives from states that have already begun implementation. And we have two great speakers today who I'll introduce to you in a minute. Let me just go through a couple housekeeping items. The session will be recorded, and both the recording and the slides are posted on our website, usually within 1 week of today's date. For those of you who provided your email address when you registered, and most of you needed to, we will actually also push out these slides and recording to that registration list so that you don't have to go searching for it a week from now and try and remember to do that. And that'll give you the opportunity to also forward it to colleagues within your organizations or outside that you think would benefit from the webinar and the slides. We really encourage questions. We find it to be really much more exciting and interactive when the audience participates, even though we're virtually together. So please feel free to use the chat function at any time during the webinar. And please chat your questions to all so that we can all see the questions that are being posed. If you have any logistical or technical questions, please use the chat to the host. So as I mentioned, we have two great speakers today, and great big thank you to both of you for joining us and sharing your expertise with those in California. Our first speaker is Allison Hamlin from the Center for Healthcare Strategies. She's the Vice President for Strategic Planning. She leads CHES's program activities related to integrating care for Medicaid beneficiaries with complex needs. And some major initiatives in this area are a contract with CMS to provide direct technical assistance to states pursuing health home programs, and also the New York Health Home Learning Collaborative, an effort designed to promote the spread of best practices within New York's new statewide health home program. And her experience in both of those initiatives will be shared today. And she has a lot to share in terms of her work with the other states and doing the state plan amendments, for example. She has a master's degree in public health from UNC Chapel Hill and a bachelor's degree in biology from Duke University. And Allison will be followed by Alice Lynn. Alice is the Manager of Grants and Program Development at the Washington State Healthcare Authority. Her staff is responsible for development, implementation, and evaluation of innovative Medicaid programs in the state. Formerly, Alice was the Senior Clinical Officer at the Center for Healthcare Strategies, where she provided technical assistance to many states in designing systems of care for high-need, high-cost populations, with a special emphasis on dual eligibles. Alice is also currently the chair of the Dual Eligibles Work Group for the National Quality Forum, NQF's Measures Application Partnership, and she also serves on NCQA's Standards Committee. Alice received a bachelor's degree in public health from UNC Chapel Hill. We see that there's some similarity between Allison and Alice's backgrounds, and a bachelor's degree in nursing from Texas Christian University. So with that, I will go ahead and turn it over to Allison.
Great. Thank you so much, Giovanna, and thank you all for joining the webinar today. We are excited to be here, and I appreciate the opportunity for a little reunion with my former colleague, Alice, who is now in the great state of Washington. So as Giovanna mentioned, one of our areas at work at the Center for Healthcare Strategies is supporting the states who are currently pursuing efforts to design health home programs or to implement health home programs under the new Section 2703 authority that was created under the Affordable Care Act. And we've been doing this since 2011 through a technical assistance contract with CMS and in collaboration with partners at Mathematica Policy Research. And over the past 2 years or so, we've worked with a great number of states and have learned a lot about the various opportunities and challenges associated with bringing up health home models, and hopefully I can share a few insights today that have come out of that work. Okay, so just to do some quick level setting for those of you who may be less familiar with the health home provision. Just some basics here. So again, this was a new service option created under the Affordable Care Act. Its overall goal is really to promote integration of services, particularly for individuals with co-occurring physical and behavioral health needs who also have needs or opportunities to benefit from greater social service integration and coordination with long-term services and supports as well. One of the greatest opportunities under health homes is the opportunity to pay for services that historically have been hard to reimburse through Medicaid programs. So for years, states have looked for creative ways, and often through pilots and other small initiatives, to pay for care coordination or care management services. And prior to health homes, there was very limited ability for states to do this at scale. And to target these types of services to certain populations and so forth. And so when health homes emerged as a new service option, many states really were excited that all of a sudden there was a new scalable mechanism to provide care management and care coordination services to beneficiaries with complex care needs. There is a lot of flexibility in the provision for states to target health homes to certain priority populations, and to address policy goals that are of primary interest to the state. And as I go through my slides, hopefully you'll get a sense of the variation in these approaches across the states. One of the very compelling features of health homes is the financing associated with the launch of the program. You may be familiar with the federal-state matching arrangement under Medicaid, and for health homes, for the first 8 quarters or 2 years of implementation, the federal government pays 90% of the tab. And so this is a big incentive for states to be able to launch these programs and sort of build capacity to deliver these services largely on the federal dime, at least up front. But given that all states know that ultimately they will be on the hook for regular state match for these services, they are very mindful, really across the board from day one in a planning effort, that these models need to be evidence-based and sustainable and ultimately have an eye toward lowering avoidable costs for the populations that will be served in health home models. Because that federal 90-10 match will only last so long, and states are very keen to that fact right from the beginning. So what are health home services? They are basically a set of 6 services that are all variations on the theme of care coordination and care management. There is a strong focus on service integration, on managing care transitions, and on patient and family-centered care planning. And there is certainly an aspiration sort of playing out in reality in different ways across the states on effective use of health information technology to help coordinate not only health home services, but coordinate health home services in the context of broader service delivery for health home enrollees. All 6 of the health home services that I just showed have to be provided, so it's not a menu that a designated health home provider can say, oh, well, I'm just going to focus on transitions or just on the care management or just on the care coordination piece. Health homes that are qualified to provide these services have to provide all 6. And likewise, the states that opt to develop health home models have to define each of those 6 services in order to launch a model. An important and common misconception about health homes is that an entity or provider that is designated as a health home, the financing associated with health homes, that 90-10 match that I mentioned, is only applicable to those health home services, so to the care coordination, care management services. The other services, whether it's primary care or mental health services or any other direct care that's provided by the health home provider, remains matched at the standard matching rates or the status quo reimbursement methodology. It is not affected otherwise by the health home designation. There are a lot of flexibilities, as I mentioned, with health homes. The services do not need to be provided within the walls of a practice or facility. Health home services can be delivered virtually. Health homes are, in many states, encouraged to use email, use text messaging, use phone, enable face-to-face outreach in the community, attending medical appointments or other appointments with enrollees. And so it really is intended to bring services to the right person at the right time and the most effective modality. And health homes are often equated or related to medical home services, patient-centered medical home or like initiatives in many states, and they can be one and the same, but they're not necessarily. They are not limited to primary care settings. And in fact, we have seen an abundance of activity on the health home front outside of primary care settings with a particular emphasis on the specialty mental health arena, as I'll talk more about in a moment. So who can receive health home services? The statute that authorized this new state option is based on chronic conditions. So the service is literally called Health Homes for Individuals with Chronic Conditions. And so states have to define eligibility for receiving health home services based on chronic conditions. States can pick any one of these little six figures or multiple of them in terms of defining who can receive services through health homes in their states, and they can further define which conditions are included. So for example, a state could choose to focus its health home program on individuals with serious mental illness and leave it at that. States could select a broad set of condition-based criteria and really target health home services, for example, to any number of chronic medical conditions as well as mental health or substance use disorders. And it really is up to the state to determine which populations by condition, which can be a limiting factor for some, are a priority and could most benefit from the availability of these services. There are additional mechanisms for targeting populations in health homes. States can target by geography. They can target services to higher risk segments of the population. But again, sort of the starting point of the conversation are the chronic conditions. This map provides a snapshot of where state health home activity stands as we speak. The states that I'd like you to focus on are the dark blue states on the map. There are 14 of them, and those represent the states that currently have approved state health home models approved by CMS. And within those states, many of them have multiple approved SPAs, and SPA is the short way of saying state plan amendment, and that is the mechanism for getting this service option reimbursable through Medicaid. There are actually 21 of these approved SPAs across the 14 states, and so again, some of these multiple SPAs relate to multiple geographies. So some states have phased in a geographical rollout of health home services over time. And some have targeted different health home models to different populations. So for example, there are some states like Missouri that have two separate health home models. One is targeted at individuals with serious mental illness, and the other is targeted at individuals with more chronic medical needs and is rooted in the primary care environment. In addition to the 14 states highlighted in dark blue, we also show states that have received planning grants from CMS to support their health home development. There is one state currently that is quote-unquote on the clock. That means they have submitted officially their draft state plan amendment to CMS, and it's currently under review. That's Vermont. And outside of what's even shown on the map here, there are about 8 to 10 states that are in active development of health home models, some of which are highlighted in the various shades of blue and some of which are not. But all told, about half the states across the country are actively pursuing or implementing health homes in one way or another. So this slide is an attempt to briefly categorize the health home approaches that are out there. Given that I mentioned sort of one of the ways into health homes is by chronic condition, this categorization really breaks out the health home models by the populations that they're focused on. So on the left, we have the states who have really developed a primary care-based approach to health homes, focused on individuals with some array of chronic medical conditions. One exception to that is Wisconsin at the bottom, which is a very targeted health home model focused on individuals with HIV. The gray box in the middle are states who are focusing their health home efforts on individuals with either serious mental illness, serious emotional disturbance on the part of children, or substance use disorder. And in addition to the states listed here, I would say that among those states that are actively developing models right now that are not yet approved, most of them are also in this bucket. We have seen a tremendous amount of activity and focus on the opportunity that health homes can provide to promote better integration of services for individuals with behavioral health needs. And then the third box represents a more broad-based approach to health homes. There's a lot of variation in the approaches represented in this box. Some, like Washington, that you'll hear about more in a moment, are really sort of extending the concept of a health home beyond the sort of four walls of any practice, be it a community mental health center or a primary care practice, and really taking more of an integrated delivery system approach to defining a health home. And others are really just casting a broad net in terms of the populations that they are hoping to serve through more traditional health home facility-based models. So I have two more slides here, and this is my last kind of substantive one. We had the opportunity to convene some of the early adopting health home states back in the fall to come together and following the first 2 years or so of implementation of health homes in these states, get a sense of lessons learned and what are the key things that will contribute to the effectiveness and sustainability of these models. And so what you see represented here are some of the key takeaways from those discussions. And we actually have a paper coming out in short order that will go into these findings in more detail, and I'll be happy to share that with Giovanna to make sure it gets its way to you all. But suffice it to say that some of the key takeaways include the real opportunity to leverage health homes in a given state to advance very state-specific policy goals. For example, in California, I know there's discussion around really targeting health home activity to individuals at high risk or individuals with particularly complex needs, and a number of states have taken that type of approach, including Washington, again, whom you'll hear more from in a moment. Others have really taken the opportunity to invest in primary care capacity and invest in kind of the medical homeness of primary care practices to do more population health management and more kind of ongoing care coordination and targeting of care management services where needed, and that includes a state like Oregon. And all of the sort of definitions and target population selection and provider qualifications and payment methodologies that go with the health home model in each of these states really fall out from what that original policy goal is. And so, for example, if there is an interest in targeting health homes for complex patients or complex enrollees, well, a lot of these states pay a higher rate for more intensive care management services with the hope of making sure that that intensity is there really for the complex folks who really need that level of engagement. Similarly, states that are targeting, again, more complex subsets of the population are in some cases paying for engagement and outreach activities, recognizing that many of these individuals are difficult to find or to engage within sort of the walls or traditional boundaries and confines of established treatment relationships. And so again, just an example of whatever the policy goal is, that really leads the state down the path of how they're defining the target population, what they are holding providers responsible for delivering, and how they are aligning incentives in order to achieve those outcomes. The third bullet here is around services should be defined to effectively engage with and care for people with complex needs. Again, given that California has voiced some interest in particularly complex subsets of the population, I thought I would mention a couple states in particular. Again, Washington, Alice will talk to in a moment, but a state like New York that similarly is focusing on a higher risk population. They, for example, have made a pretty deliberate requirement for partnership and collaboration with housing in their health home qualifications and health home service requirements, recognizing that for many folks with higher level healthcare needs, they also have some basic social service needs and some very fundamental needs around housing that health homes need to attend to. The last few points I want to make here are just recognizing the substantial transformation that is involved in the shift to a health home model for many, many providers. And I think the states that have been at this for a while really recognize that and are really investing in the capacity building that is needed for providers who want to participate in this model to do so successfully. And so, for example, New York, as Giovanna mentioned, has invested in a learning collaborative and is providing infrastructure funding kind of outside of the health home statute per se, but is providing state-only funding to help build some of the infrastructure, whether it's HIT or otherwise, workforce training, et cetera, that providers need in order to really deliver on the health home model. And another area of the support is access to data and information, and I think many of these states have very much realized the importance of making sure that actionable, real-time data is available and accessible to health home providers. If we expect health homes to manage transitions of care, well, they need to know when someone's in the hospital. If we expect services to be integrated, we need to have mechanisms of sharing information about care delivered in one setting to another setting and so forth. And I think this is an area where we will see more growth and development and attention in the years and months ahead. So lastly, before I hand it over to Alice, I just want to put up a resource here that you'll get when the slides are available to you. This is the link to the Health Home Information Resource Center on the Medicaid website for CMS. And there you can find a lot of resources, some of which are designed for states, but there's a whole repository there of information that is broadly relevant to individuals who are interested in health homes. So with that, Alice, I will turn it over to you, Giovanna, unless you want to take any questions first.
There are a few questions. One is, are you aware, as other states roll this out, you know, it's obviously specifically for Medicaid patients, do you know if other states are trying to kind of replicate the model for commercial or Medicare payers?
Yeah, that's a great question. And I think a long-term goal, probably for all, is to have a multi-payer aspect to health homes and certainly alignment of the Medicaid health home service with other funded care coordination or medical home type models. I think certain states have taken a more active approach to this than others. Maine and Oregon are two that come to mind. Maine's initiative has been multi-payer, I believe, from the get-go, as has Oregon's. And so when the health homes option came out, Oregon really built upon an existing multi-payer, patient-centered primary care home initiative that was already under place. And again, I think the view of most states is that in order for these to be sustainable, there needs to be some alignment across payers in order to make this more operationally viable for providers. Great,
and one more question. Are there any states looking at this model for NICUs? I assume that means for high-risk infants?
Oh, that's a great question. Well, one challenge is sort of the condition targeting here, and I'm not aware of, the only thing that comes to mind is, I'm sitting here just brainstorming with a colleague, North Carolina included sort of a kicker payment, so to speak, an enhanced payment for health homes for high-risk pregnant women, I think with the goal of avoiding NICU outcomes. that I think is the closest thing there is to a NICU focus model per se. It's a great question.
Okay. We do have a couple more that I think we'll answer before we move on to Alice. Who determines the target population, Medicaid or the providers? And I assume that also means does the state, does any state target a population by the top 10% who are the most complex?
So interesting question. So first and foremost, I would say that most states have used a pretty broad stakeholdering process to develop their health home models, and so providers and other stakeholders in the community have generally had a voice in the health home development, certainly in the more successful health home models out there. So it is up to the state ultimately to define which target population they would like to include. Again, the statute requires a definition based on chronic conditions, but within that framework, there are certainly states that are tailoring their models more to high-risk populations kind of writ large, and Washington State is a great example of that, and Alice presumably can talk more to that in a moment. Giovanna, should I turn it over to Alice, or did you want to ask another question?
Sorry, there were a couple more questions. Sorry, I was on mute. Do states certify health homes or NCQA? There is no certification for this, correct?
Oh, great question. So, states do qualify health homes, and it's sort of played out that way. I don't know that there is a requirement in the federal statute per se that states that health homes have to be certified, but most states have developed some type of bar. The state has to define qualifications for individuals who can deliver health home services, and most states have had either a formal application process or at a minimum some very objective criteria for determining whether or not a provider is qualified as a health home. There are some states who are using NCQA, patient-centered medical home standards, as a proxy for health home qualification. I think we saw that more at the outset in some of the states that went after health homes earliest. I think we haven't seen as much of that lately, but certainly for states that have a robust PCMH initiative, there has been a strong interest in leveraging that platform for health homes and building on that platform for health homes.
Okay, two more questions, and then I'll start curating the questions for the Q&A at the end. Does being a Medicaid expansion state affect implementing this model at all?
Great question. So no, I would say that there is some linkage in terms of the states that are more inclined to take advantage of various ACA provisions for Medicaid. In terms of their willingness to pursue this option, but there is no express linkage. So a state that is not pursuing Medicaid expansion can certainly pursue the health home option if they are interested. And it's also a good opportunity to note, though, that health home services, to the extent a state wants to make these services available, they can choose whether or not they're available to the expansion population. So if a state offers health homes, they have to be offered to traditionally eligible, categorically needy Medicaid eligible populations. And most states that are expanding are choosing to also make them available to the expansion population, but it is not necessary or required that they do that.
Okay, great. And then a clarification / follow-up question to the question before about how the population is identified, and I think Alice will also address this. Who actually IDs the patients who are going to be receiving the care in the health homes? Is it Medicaid through its data, or does the provider organization identify the patient population?
Great question, and that's really up to the state to define, and we're seeing both models play out. And so in some cases, and again, Alice can speak to this in Washington, the state is identifying based on kind of Medicaid administrative data individuals who are presumed to be eligible to receive health home services based on how the state has defined those criteria. And in many states, they are either in addition to or as an alternative to that method, giving providers the ability to refer and make recommendations for eligibility for health home services.
Great, thank you. So Allison, if you can pass the ball to Alice, that would be great.
Okay, she should get that in just a second.
Okay, Alice, there you go.
Okay, thank you, Allison, and welcome again this afternoon. There we go. I'm speaking from the Washington perspective, but as Giovanna mentioned in the introduction, I recently came from working with a number of states on implementing their new programs for dual eligible people on Medicare and Medicaid. So I'll talk a little bit about how that population is also being served through our health home model in Washington. And I think there's some good fits and efficiencies there in our Washington model. So I would like to just start by giving you a little bit of background for how Washington's Medicaid program is managed here. We have two state agencies separately reporting to the governor for the management of Washington's Medicaid program. So the Health Care Authority manages the medical services and with a little bit of overlap of mental health services, and the Department of Social and Health Services manages the mental health, long-term supports and services, and chemical dependency services, and specialty services for people with developmental disabilities. We have over 1 million people now that we've gotten through the enrollment through the expansion population. We have over 1 million people enrolled in Medicaid now in the state of Washington, 80% of whom are enrolled in managed care. The last big group, similar to California, was to ramp up managed care for people who have the eligibility related to their disability status and blindness, and that happened in 2012. In our state, we do have 5 managed care organizations, so a little bit simpler program to manage in some respects than in California. In the state of Washington, because of the split of responsibility for the Medicaid program, and just because of the nature of how services are delivered at the community level, there are sometimes fragmented service delivery and a lack of overall accountability, even for people who are in managed care, because folks who receive managed care for their medical services and their mental health services are managed through 2 separate programs with 2 separate contractors. Those folks can sometimes have a disconnect in the handoff for overlapping services, and the long-term services and support side, very few people have their services managed by some integrated program like the PACE model, or a very small integrated program that we have in one county of Washington state. So we realized that because of that fragmentation and the overlap of the use of services, that we were really kind of struggling to make case management work on the managed care side and on the mental health side, let alone having those 2 seamlessly integrate with folks who overlap the need for services. So here's a diagram that just shows how our population uses services in an overlapping way. So this represents the folks who are Medicaid-only folks, so the non-dual eligible Medicaid-only population in Washington. About 1/3 of them are served by, and this is for those who are considered high risk or high cost beneficiaries, about 1/3 of which are served by the long-term care system, Aging and Long-Term Services Administration, a small overlap with the developmental disabilities population, a huge overlap with people who are able to be identified as having a serious mental illness, and then also overlap with all of those populations and people who use chemical dependency treatment services. So, so that shows the folks who are Medicaid only, and then a different kind of Venn diagram for the folks who are on Medicare and Medicaid. In that population, 95% are served by long-term services and supports. So you can see that the overlap is quite different there. And obviously in both of these groups, almost all of them use some services on the medical side. As Allison mentioned, a number of impetus came together to inform the health home model. So, first of all, there is the support for health home development in the Affordable Care Act. And then in this state, we also had a state law that supported our going ahead with developing and implementing the program. Because at the same time we were considering applying for one of the duals demonstrations through the federal government, we began doing a statewide stakeholder feedback process where state officials, and with some support of the Centers for the Center for Healthcare Services, we actually went out and did stakeholder focus groups in several counties around the state to ask folks what were the barriers to improved care management for people who used multiple services in their local areas, and what kinds of strategies they could think of that would help improve those services. So a lot of the feedback that we got through those focus groups were really reinforcing the need for more accountability in the system, to align the incentives across the various service delivery systems, to provide individuals with a single point of contact and care coordination that was much more intentional as opposed to kind of scattered across the various systems. But also, people really did talk about what works at the local level now and asked us to improve on what works and increased the flexibility to allow people at the local level to deliver these models differently. So all that to say that in the end, we decided in Washington to go for two different models for the dual eligible Medicare Medicaid population, one that utilizes capitated managed care and one that is based out of this health home model. And that kind of ties together both populations that were shown in those two different diagrams, the Medicaid only and the Medicare Medicaid folks. So the important thing to know about how we decided to implement, again, there were many things underway already at the local level that people in our community focus groups asked us to build on, one of which is that there were already, through the local area agency on aging organizations in several counties, a care management strategy that used the relationship that the AAAs had with individuals to build on that, identify the high-risk folks, do some intensive case management or care management that built on knowing the health activation level of folks and built as a very individualized care plan that helped folks learn how to manage their own conditions better. That program had always been restricted to people who were Medicaid only, and one of the benefits of doing this health homes model for both Medicaid only and dual eligibles was that we were able to broaden our approach to the population to get to that big 95% of folks who use the long-term supports and services system and are considered high risk in our program. So here are the goals of the program. Again, building on what we knew was working already to establish person-centered health action goals. And again, these are growing out of a very person-centered care plan and assessment. We wanted to make sure that the coordination addressed the full continuum of services, so not just in a siloed way, but across all the different services that people needed or used. A lot of emphasis on coordination and transitions of care as people move in and out of home-based care and institutional care. Because of our knowing that the activation level of folks when they first entered these programs might be dangerously low, that we really wanted to increase people's skill level in self-management around their unique self-management goals. And then again, to have that single point of contact back to the big systems so that folks would know who to call for getting linkages to the rest of services in Medicaid. So the focus on high-risk enrollees, as Allison said, we used that kind of middle stick figure where we not only identified people with one of a number of health conditions using diagnosis codes, but also focused on those at higher risk for future utilization. We were able to do that in Washington because of a unique blended data system that is managed out of the Department of Social and Health Services. That data system called PRISM is able to put in all the different service components, including medical, long-term services and supports, mental health services, et cetera, and then generate using some algorithms particular risk score that's identified with each individual. We use that risk score to pull the population for enrollment, and those folks are the ones most likely to use future Medicaid services, and especially those high-cost institutional services like emergency department and hospitalization. So, really, as Allison said, the ability to achieve a return on investment was foremost in the minds of the people who were developing this model in concert with the legislature. And so our ability to achieve return on investment was partly supported by using this focus on the high-risk group. Again, this just reiterates how we pulled the eligible beneficiaries. Most of them do have very high rates of emergency department use, hospitalization, and a high rate of rehospitalization or readmissions to the hospital as well. And the risk score that we use for the identification of the population is 1.5 or greater, so 50% more higher risk than the general population in Medicaid. This diagram shows a health home umbrella of services. So, again, the image that we like to use is that, folks feel protected by this model. Once they belong to the health home, they have this kind of coordinated coverage that helps link them to all the different services they might use. The state, through the Health Care Authority, has a contractual relationship with these health homes, and again, similarly to other states, we had the health homes go through a request for proposal process. Readiness review was determined through on-site visits and review of their paper files in advance, so that we were convinced that a network of all these different services was available to serve people. The health homes can provide care coordination themselves, but in general build a network of care coordination organizations in order to serve all the different needs of folks. So depending on whether the primary need is mental health or long-term supports and services or medically complex nature of the person, they are able to selectively enroll in these different care coordination organizations. A couple of tweaks to the 6 generic services that are authorized by the health home model are a couple technology supported services that we introduced in Washington. So number one, we have health action plans. Again, these are very person-centered plans, but we use a number of standardized screening tools and also a couple of very sophisticated assessments called the patient activation measure and the caregiver activation measure. And these help guide the care management staff to gear their education to the appropriate level as folks start getting a handle on how to take better care of their conditions and help reach the goals they've set. The health action plans are uploaded into a centralized database, and we are just starting to get a view of those reports now. It's quite gratifying to see that just the kinds of goals that we were hoping to see are starting to emerge, so that individuals are setting goals around their exercise level, their desire to quit smoking, their desire to have healthier lifestyles, their desire to stay in their own homes, et cetera. So, really wanted this to be a kind of broad and person-centered approach, not disease-specific. A couple other things that are available to support the program through health information technology. One is that on a number of local levels, emergency department information is exchanged, and that helps with that kind of real-time access to data that Allison mentioned. And the PRISM system that identifies the risk level for folks is also available to the care managers for the folks who are in their population, so that they're able to view the historical utilization of services, the medications that have been prescribed for them in the past, the kinds of things that they've shown up for in the emergency department in the past, et cetera. One Healthport is the name of the system that supports that health action plan data interchange. So a number of unique data systems that were created just for this program. Here's a map of the state of Washington that shows the coverage area crazy quilt is what I call it. In each of these coverage areas, we have multiple qualified health homes, and the health home lead entities that are listed in the little boxes in each area include both community-based folks and also some of the managed care plans who serve that 80% of the population that I described earlier. So that allows us to selectively enroll with the different health home leads according to the folks that they are already serving if they're in managed care, and allow the community-based folks to serve predominantly fee-for-service clients who are most of the dual eligibles. In the middle of the state there in King and Snohomish County is where we will be enrolling folks in the capitated model under the financial alignment demonstration. So those are two areas of the state where we will not be bringing up a health home model. So the next slide shows the payment for health home services. Our very first engagement is reimbursed at $252. That is the rate that pays for all the work that goes into outreach and the initial health action plan completion. After that, most folks go into intensive care coordination for at least, what we predict will be at least 6 months or a year. But we do allow a lower level maintenance rate because we anticipate that there will be some people who don't need quite as intensive a level of ongoing services, but who want to stay linked up to the health home care manager for at least ongoing telephonic management and so forth. Most of the intensive care coordination services we anticipate will be face-to-face in people's homes. We realize that at times that might not be possible, but for the most part, we think that those intensive services will be delivered in the home. So a couple last slides for me are just about what we've learned over the first several months of implementation. And first, just wanted to show you one example of one of our qualified health home leads, Optum. Optum is a managed behavioral health organization, but it also applied to serve our population as a lead health home. They have an emphasis on the creation of those community partnerships, care coordination staff, a lot of high-touch service delivery, and they came up early in several parts of the state. They contract with 10 care coordination organizations throughout Washington, and their special area of focus are for folks with mental illness, but of course they take, you know, folks with all of the range of different services. So they have a network that includes area agencies on aging, the chemical dependency treatment centers, and FQHCs to serve medically complex folks. This is their lovely pre-implementation picture of what they were hoping for in terms of getting a home run going on this program. And when they hit their mark of successfully having gotten a good number of folks through the system, they sent this back to us to say, you know, it seems like they really did know what all the different components were going to be, and were aware of the challenges and the vision for this program going in, and so just felt like they had gotten successfully through the first 6 months. A couple of the challenges that all the health home leads have expressed to us, though, are number one, locating and engaging folks. That has always been a problem in Medicaid, but having folks who are high needs that you would expect to be a little easier to find because they make contact with the system pretty frequently turned out not to smooth things out as easily as we had hoped for. So that has been the number one challenge for all of our health home leads. Planning for the capacity of the network has also been a real challenge, and so we're trying to really build up some of the information sharing that we have in place for the health home so they know who to expect when to be in their enrolled population. And then, you know, the systems that we developed that I described earlier, we had, you know, developed to make the information transmission easier on our end, but it has not always been easy on the health home, and in turn has posed challenges to some of the care coordination organizations, because even though they are, you know, quite automated on our end, they turn into multiple different strategies in the relationship between health homes and care coordination organizations. So if they contract with multiple different health home leads, it creates differences among the caseload standards, the requirements from the health home for the amount and type of contact with clients, et cetera. And then, you know, not to mention the fact that these are just complex folks to manage. That is a challenge too. But we really do feel like we've had quite a lot of success in the early part of the program, have really accomplished a lot in terms of outreach and the participation and relationship building across the different stakeholders and those who serve these folks. We have trained over 300 care coordinators in the model of chronic care management that we believe in, and so really hoping that this model builds towards success under our health reform in the future. So thanks very much for the time today, and I think we have a little bit of time here still for questions.
Yeah, we do. If you could just advance to the last slide, Alice, that'll help folks as they sign off, just as a reminder that we will post the slides and the recording in a week. And we do have about 4 or 5 questions in the queue, and we will go over 1:30 for those of you who want to stay on and listen to the questions. I just want to make sure we have an opportunity for folks to get their questions answered. For folks of you who have to sign off early, please take a moment and complete the poll, which is just a very brief survey of today's webinar, and you can access that by clicking the polling tab on the top right. So I think this question is probably for Allison. Allison, are there any states like California with a high managed care penetration? And if so, how does the incentive work? Are plans required to pay the providers for more care management?
Yeah, great question. And just earlier today we were talking about this, so this is a very timely issue. So the answer is yes. I would include Washington on that list. New York is another one. And many of the other approved states also have significant managed care enrollment among their health home eligible populations. However, I think many states have been a little shy about connecting the health home model to managed care to date, with a couple of exceptions, including Washington and New York. But I think most are on a path, winding as it may be, for closer integration between their managed care program and their health home program, recognizing that it probably doesn't make sense to have kind of a community-based care coordination program totally outside the managed care program. New York is an interesting data point for the question. Pretty much everyone in New York at this point is enrolled in managed care or soon will be. And the managed care organizations are required to contract with at least one health home that's operating in their area. And the health home payments are passed through the health plans to the health home providers. So the plans are receiving new money for this purpose. So it's, a clear and distinct payment outside of the capitation rate at this point. Ultimately, I believe it will be folded in, but right now it's a separate payment that runs through the plans. The plans are allowed to negotiate with providers to retain some portion that is capped, I believe, at sort of 6% overall. And I think most plans are withholding less than that in order to support the administrative function of the plans in managing health home services and supporting the health homes with information and so forth. Washington, again, Alice can speak to in terms of the, I think she already mentioned that in many cases the health home lead entities in Washington are the health plans, and so there's some clear integration there. But this is an area where I think we're going to see a lot of evolution in the months ahead.
Great, thank you. Question, since the health home option is a 90-10 federal match, the population we are considering for California's program is largely the adult expansion / 100% federal match population. How do we get the best, quote, bang for our buck for this?
Great question, and there's good news there. I believe we've confirmed, and we have that health home services for the expansion population are matchable at 100%. And they follow, as that curtails to 90 whatever over whatever period of time, it follows that track. So states have that much more incentive to make these services available for the expansion population, absolutely.
Great, thank you. And Allison, are you seeing any of these early health home states actively integrating palliative care into the services that they're offering?
Oh, that is such a good question. I am not aware of a great model to date. I would say that Washington is the state that has had the most robust inclusion of long-term services and supports, generally speaking. And I know that's a different spin on palliative care, but along those lines, I think has more robust inclusion of providers who are familiar and adept at palliative care approaches. And so, Alice, not to kick the can, but I wonder if you have any thoughts on the question, because Washington would be the place I would look to for the best integration of that type of approach.
So say again, what was the question?
The question was, are you in Washington State integrating palliative care into the services that you're providing for these complex patients?
Yeah, I had looked at that question when it first came in. We would not want to take over for the role of hospice, for example, but I can see how for folks who are not engaged in a hospice program that it could be a really helpful role to have health home folks involved in the care management. So it took me down quite a thoughtful path when I saw that question come in, and need to loop back to our folks who do the education and training around this about how we could weave that in a little bit more explicitly, because there certainly are a number of folks who would qualify for that kind of palliative care program who are enrolled.
Great. There's there's 5 questions. I'm going to kind of combine them that we can finish with, so I won't take any more past Lydia's just for the sake of time. Alice, 2 questions for you. What was the size of the high-risk versus predictive future high-risk populations relative to the total $1 million that you mentioned?
So compared to the 1 million folks, that we think it's somewhere around 20%, but you know that bar kind of goes up and down a little bit, and of course out of the million folks, King and Snohomish County, who are carved out to the capitated model, certainly have some of the bigger population centers in the state. So King County is where Seattle is, for example. So a big chunk of folks are out of that million. Right at the beginning. We anticipate somewhere in the neighborhood of 30,000, 40,000 people being enrolled at the end of the day.
So about 20%, that was your sense?
Mm-hmm. Yeah, yeah.
Okay. When do you expect to see your ROI?
So good question. Part of it relates back to because we are counting on the arrangement with the federal government to support us with the duals demonstration. We're counting on achieving some performance measurement payment to kick back in within a few years out. So there's, you know, we're about cost neutral or a little bit cost savings in the first couple of years, but when the 90% match ends, there's a little bit of a dip, and then we're counting on the payment related to the financial alignment demonstration to kick back in and bring us back up to a cost savings standpoint. So it's about 4 years out.
Okay. And then one tactical question and a sort of final 2 questions about PCMH versus health homes and the new information that was just published recently on the RAND study of primary care medical home. So the more tactical one for us is, what is the expected length of stay in health homes? We are finding, and I'm reading directly, we are finding in our pilot project that the most complex patients need ongoing services even as they get more stable. So they need a different level of service, but they need some. Alice talked about a maintenance payment. Is there any time limit on enrollment in terms of being in the health home?
Yeah, not from our standpoint. We haven't talked about you know, any forced graduation of people. It's really between the individual enrollee and their care manager.
Yeah. And I would just add from my standpoint that I think the vision for health homes is that it's a service that is continuously available and is titrated to meet the level of need over time. And so I think states are really finding that it's important to have some type of tiering in the payment structure that allows folks to access, you know, continuously to a certain level of service, but obviously it would be unsustainable to pay for intensive services when they are not needed.
Great, thanks.
Back to the question about the prospect for improving outcomes. Here in Washington, the model that we developed is very much rooted in a chronic care management program that had been in place for several years, as I said. And that model, we have just done a repeat study that again shows statistically significant changes in the mortality rate of engaged beneficiaries. And even when you compare folks from in an intent to treat model, where it's all the folks targeted for the intervention compared to a parallel group who are not in the intervention, even in that approach, we have seen significant differences in utilization and a meaningful difference in mortality. So we know that we have the capacity to have a meaningful effect on these folks' lives, and it all really ties back to, can we get in the door in the first place? So, you know, the main difference between that model that we have shown really does produce good effects in the long run, and the model that we're trying under health homes is that you know, we really have to get to that engagement rate in order to show success. And so that's our big challenge right now.
Great. And Allison, do you have any comments kind of about the difference between PCMH and health homes as they're described, or how folks are, I guess, rolling them out within 2703?
Yeah, no, it's a great question, and that study came across our radar as well. You know, I think there are some really key differences, and again, every state's model is different for what health homes look like, but generally speaking, it's a far more intensive mode of kind of care management and care coordination, really targeted at, to one degree or another, a higher risk subset of the population. And so I think most of the medical home studies are more of a population-based approach, both in terms of the service model as well as the evaluation methodology. So, you know, I think most states are looking to deliver kind of a higher intensity care coordination service to a smaller subset of folks who could really benefit from that level of care. And unfortunately, there's not a lot of data out there right now on models like this at the scale that health homes are currently being operated to really be able to say definitively, you know, how long it will take to prove whether or not there is an ROI. We're starting to see some early promise. I think in the weeks ahead, there will be some initial evaluation results shared in Missouri. New York has some very preliminary data that they are looking at that, while, you know, perhaps not publishable in the New England Journal at this point, given all of the caveats associated with early analyses, they show some promise, and they show what can happen when you really effectively target these types of these models to the folks who really stand to benefit and for whom, you know, there's enough avoidable costs in order for that ROI to be achieved.
Great. And then two final questions for Alice. Alice, do you know the split between the high risk versus predictive future high risk of the 20%?
If I had actually made it sound like there was a split, there's not a split. The 20% are the folks who are at that 1.5 risk level, and that does represent the people who are at currently, you know, they have a background of utilization and diagnosis that shows that they are at future risk for expensive care.
Got it. And then is there any publicly available information on the outcomes of your program in Washington where you described the savings?
Yeah, we sure do have that. There's an original report was done in 2009. I can send that to you, and the new updated study should be released fairly shortly, and I can get that to you as soon as it's published.
Great. If you want to share with me the old one, I'll share it with the folks on the phone. So thanks, Allison and Alice, so much for sharing your expertise on this call. It was very engaging to hear from you and lots of great questions from the audience. And thanks to all of the participants who took time out of their day to call in. Thanks so much, everyone.
Thank you. Bye-bye.
Thanks.